to your academic schedule. I hope everyone knows what the academic schedule is and is following it. If you have any questions, you can approach me, Aish, or Lolita about it, or one of your uh, classmates. All right, so growth and development. You have to you have to start with basics. So the basic thing is knowing your measurements. The most powerful tool that you have in terms of determining the growth of a child is your growth charts. And you have to have measurements as much as possible. So height, weight and head circumference, you will do in all infants and toddlers. Uh, and in older children, you will do a stature, meaning height, and calculate BMI. You have to do these measurements without shoes, in young kids without clothes, and in kids who are less than 2 years of age, they are recumbent, and in those who are older than 2, they stand, and the best tool to use is a standometer, which we have in clinic in all of our rooms. The measurements should perform in an infant naked and ideally, and repeated measurements should be done on the same equipment. The head circumference is determined using a flexible tape that runs from the supraorbital ridge to the occiput, and this is a standometer right here. You can see them in each of our examining rooms. You have one. So the growth charts. The the World Health Organization released standard charts in 2006 for children. They did a multi-center growth reference study that described the growth of children who are predominantly breastfed and raised under optimal options. And 6 studies sites were included in the 5 different continents: the United States, Brazil, Norway, Ghana, Oman, and India. And those charts are what we use for all children under the age of 24 months. Before, we used to use CDC growth charts, but they were CDC growth charts are based on white children in the 60s. So the measurements do not apply to the general population, especially before the age of 2. And that's why several years ago, we was decided that to be more accurate with our diverse population, we were going to use the WHO charts before the age of 24 months. So these are the charts that we usually use. We have an EMR, so you might not be able to see these charts like this, but if you press, we can show you how to look at them in the clinic if you are not familiar with it. And we look at length, weight, we look at head circumference, and we look at weight for length for children under the age of 24 months. And these are the CDC charts that we do use for kids who are older than 2, because after 2 years of age, kind of like everyone approximates, excuse me. And as you can see here, we look at stature, we look at weight, and then we look at BMI. So growth patterns. It is important for you to know growth patterns and to be familiar with them, because you should know them. But also, a lot of your testing on the boards, on your in-service exams, are going to focus on you understanding those growth patterns. So in a normal infant, they usually lose up to 10% of their birth weight in the first week of life, and they regain it by the second week. They will gain steadily a rate of 20 to 30 grams per day for the first 3 months of their lives. And for full-term infants, size at birth reflects the influence of the uterine environment. Most children tend to track along a percentile referred to as following the curve. And between 6 and 18 months of age, infants may shift percentiles upward and downward towards their genetic potential. Size at 2 years of age correlates with the mean parental height, reflecting the influences of their genes, not the uterine environment anymore. And most children will track along growth percentile with variations within 2 large percentile bands, between 2 standard deviations. This tracking often represents the mid-parental height and a corresponding weight to that mid-parental height. So here we have from Nelson's kind of like the growth and caloric requirements for children. And as you can see, in the first 3 months of life, they gain around 30 grams per day. And that decreases as I get older. And this is their caloric requirements. And you should be familiar with this because these are fair questions and you're testing and things that you should know. For weight, the weight doubles at 4 months of age, it triples at 12 months of age, it quadruples at 24 months of age. And weight gain that is less than 1 kg or 2.2 pounds per year in a prepubertal child is of concern. And here again are the expected weight gain as the child gets older. Growth. So the average, one second. The average length at birth is 20 inches. And, children will grow around 10 inches or 25 centimeters in the first 12 months of their lives. Then they will grow around 4 inches from 12 to 24 months, 3 inches from 24 to 36 months, and then grow around 2 inches or 5 centimeters per year from 4 years to puberty. The height is increased or gained like 50% of the, in the first year. It doubles by 4 years of age. It triples by 13 years of age. And linear growth less than 5 centimeters or 2 inches per year in a pubertal child is of concern, that you should be familiar with. So the midparental height is kind of like the target height that will be normal genetically for a child when you're looking at if their height is appropriate, and then you look at the weight that is that should go with that height. So these are the calculations for the midparental height. You should know this by heart because you should be able to, assess the midparental height for children that you're looking after if need be. And, these are fair questions on your boards and on your in-service exam. So for boys, it's maternal height plus 5, and that would be 5 inches, plus paternal height divided by 2. And in girls, is maternal height plus paternal height minus 5 divided by 2. And if the question is in centimeter, then instead of 5 inches, you use 13 centimeters instead. And the target height for a child is equal to the midparental height plus or minus 2 standard deviations, or 1 standard deviation being 2 inches. Now, the other parameter that we follow in infants to the age of 36 months is head circumference. And for that, we use a flexible tape. We measure usually 3 times from the occipital area to the frontal circumference, and you record the greatest or the number of the 3 measurements. The average head circumference for at birth is 35 centimeters, and you should have that in mind so you can when you see a baby, you know which is this child microcephalic or macrocephalic. And it increases around 1 centimeter per month in the first 12 months of life. And most rapid growth happens in the first 6 months of life. And then increases 2 centimeters in the first month, 6 centimeters in the first 4 months. And the majority of head growth is completed by 4 years of age. Now, BMI. So BMI is what we use to assess if a child has normal weight, is overweight or obese after the age of 2 and above. So in our EMR, the BMI is already calculated for you, but you should be familiar with the formula. So in case you have to calculate it in your exams. The BMI is somewhere between 5 and 84 percentile. Below 5 percentile is underweight. Above between 85 and 94 percentile is overweight, and above 95 and above is obesity. So let's go over a normal infant. Again, right, we said that before, loses 10% of their birth weight in the first week of life and regains it by the second week of life. They will then gain steadily at a rate of 20 to 30 grams per day for the first 3 months. For full-term infants, size at birth reflects the influence of uterine environment. And again, most children tend to track along a percentile, referred to as following the curve. Between 6 and 18 months of age, infants may shift percentile upward or downward towards their genetic potential. Size at 2 years correlates with mean parental height, reflecting the influence of genes. And most children will track a longer growth percentile with a variation within two large percentile bands. A small infant might track between 5th and 25th percentile, a large one between 25 and 95th percentile. This tracking often represents the mid-parental height and corresponding weight. So this you should know very well. So important to correct for various factors in plotting and interpreting growth charts. So for premature infants, overdiagnosis of growth failure can be avoided by using growth charts developed specifically for this population, although this is not our usual practice. So what we do is we correct for their age. So you can subtract the weeks of prematurity from the postnatal age when plotting growth parameters. Does not capture the variability of growth velocity that very low birth infants can demonstrate. So, but if you have a premature child who's low weight, this can be helpful. So for very low birth weight infant, most achieve weight catch-up during the second year of life and height catch-up by 2.5 years of life. Children with particularly tall or short parents, there is a risk of overdiagnosing growth disorder if the parental height is not taken into account, or conversely, of underdiagnosing growth disorder if the parental height is accepted as the explanation for them being short. So you have to keep all these things in mind, but you have to make sure that nothing's wrong, especially with short stature, and you just can't blame that the parents are a certain height, since especially in our practice where we deal with immigrant population that has been displaced in their own countries and are displaced here. Parents might have a certain height, but they probably didn't achieve their full growth potential because they themselves were probably under malnourished as children. So it's not unusual that we'll have in our clinic, parents that are 4 feet 9 inches and their kids are like 6 feet tall. So that just tells me that their parents were growth stunted. So that should not be the explanation. You always have to look into it. So linear growth deficiency or stunting is more likely to be a result of congenital, constitutional, familial, or endocrine causes than caused by nutrition deficiency. So endocrine disorders, length or height declines first at the same time as weight. Weight for height is normal or elevated when you have an endocrine disorder. In a nutritional insufficiency, weight declines before length, and weight for height is low unless it has been a chronic stunting for a while. Now, another concept that you have to be familiar with is failure to thrive. And failure to thrive is a diagnosis of children under the age of 3. So you cannot be failure to thrive after the age of 3. After the age of 3, you're underweight if your weight is not normal. So consider if a child weight is below the 5th percentile, if it drops down more than 2 major percentile lines, or if weight for height is less than 5th percentile. So this is like the definition of when you consider failure to thrive. Weight for height below 5th percentile remains the single best growth chart indicator of acute undernutrition. A BMI less than 5th percentile also indicates that the child is underweight in a kid who's 3 years or older. Children who have been chronically malnourished may be short or stunted as well as thin, so that their weight for height curves may appear relatively normal. So you have to be careful with that. Chronic severe undernutrition in infancy may depress head growth, which may be an anonymous predictor of later cognitive disability. And low weight for age or height or weight loss may be referred to as wasting. So the diagnosis of failure to thrive emphasizes the deceleration of growth in stature or weight and includes psychosocial and developmental concerns as integral parts of the diagnosis. So non-organic failure to thrive suggests insufficient emotional or physical nurturing, described as a reactive attachment disorder. And children with failure to thrive can have recurrent infections to impair immune systems secondary to malnutrition. When you get a child that seems to be failure to thrive, you should assess a dietary history, the method of feeding, if they're breastfeeding, the maternal diet, formula preparation, value consumption technique. That's the first thing you should do. And you should look at the parental attitudes and habits around eating. Children of mothers younger than 18 years of age have poor growth, especially during the first year of life. And these are just facts. Children of mothers younger than 18 years of age were 2 times as likely to experience maltreatment, mainly neglect, than those born to older mothers. And hospitalization for failure to thrive remains a mainstay of management if the child is refractory to outpatient treatment. So a long time ago, when you got a child who was failure to thrive, we used to use it as a diagnosis of exclusion. That is not the case anymore, because most kids who are failure to thrive is because of an anorganic cause. So you have to look at it differently than we used to. So when you look at children in real life, when you are answering questions, always look to see that we have done all this before we start a very expensive workup, okay? So obesity, and obesity is something we diagnose after the age of a child whose age of 2 or older. So growth chart can confirm an impression of obesity if the weight for height exceeds 120% of the standard median weight for height. According to the CDC, a BMI over 95th percentile indicates obesity, and a BMI between 85 and 95th percentile indicates overweight. BMI may not provide an accurate index of adiposity because it does not differentiate between lean tissue and bone from fat. So it has its limitations, and you should understand those limitations. Measurements of the triceps, subscapular, and suprailiac skin fold thickness can be used to estimate adiposity. Considerable experience is needed for this accuracy. That's why we don't do it regularly in clinical practice. So also abdominal girth may help to determine if the child's height BMI, high BMI is due to muscle mass versus adiposity. And we do this in clinic. We have these prepubertal boys who are very muscular, and they seem to be overweight. So we usually will go ahead and do an abdominal girth just to show that it's normal, and just document that the BMI being above 85 percentile is because of the lean muscle mass. So complications of obesity includes insulin resistance, which can lead to metabolic syndrome, which can lead to diabetes type 2, which can have other complications of health, like obstructive sleep apnea, fatty liver, which we see a lot in our clinic. And remember that fatty liver is really important to treat, because if you have a fatty liver from obesity, it can go to hepatitis, to cirrhosis, liver failure, and need of liver transplant. I've heard many times that in the next few decades, the #1 cause for liver transplant in people in their 30s would be this entity secondary to obesity. There's other indices of growth that you should be familiar with. So the head and trunk are relatively large at birth, with progressive lengthening of the limbs throughout development, particularly during puberty. So the lower body segment is defined as the length from the symphysis pubis to the floor, and the upper body segment is the height minus the lower body segment. The ratio of the upper body segment divided by the lower body segment equals approximately 1.7 at birth, 1.3 at 3 years of age, and 1 at 7 years of age. So the higher and upper to lower body segment ratios are characteristic of short-limb dwarfism or bone disorders such as rickets, and a lower upper to lower body ratio characteristic of Marfan syndrome, in which patients have tall stature with the lower segment of the body greater than the upper segment. So now let's go over specific growth disorders. So growth curve analysis. When you look at growth curves in real life and when you look at growth curves in your test, do not consider a single measurement. Having a single measurement doesn't tell you much. The first step is to get the old measurements to compare in real life and in your test. So the next step is to get the old measurements if you only have one single measurement, both in real life and in your test. So we have our regular growth curves, which we discuss, but there are special growth curves that exist for specific syndromes and abnormalities. So, as we said before, our method of using chronological age to plot children on our regular growth curve does not work for very low birth weight infants. So you can use a very low birth weight chart for those infants. Down syndrome also has their own growth curve, Turner syndrome, Williams syndrome, Prader-Willi syndrome, and achondroplasia. And those you can find in your Harriet Lane and use them if need be. Preterm infants, as we said before, for preterm infant, unless they're very low birth weight, we can use our standard growth charts. And by the time we get a very low birth infant into our clinic, we can use the standard growth chart because they're like 3 months old already. They've been in the NICU for weeks. Correct growth parameters for gestational age. So subtract the number of weeks the child was premature from the postnatal chronological age. Correct as follows for weight until 24 months of age, because that's when they catch up. For stature until 40 months of age, because that's when they catch up. And for head circumference until 18 months of age, because that's when they should have caught up. A fetal growth restriction. So going now to neonates, we should be familiar also with their growth patterns as well. So we know how to best treat them or follow them when they come to our patient setting. So the definition of growth restriction is a fetus that does not achieve expected in utero growth. They usually have a fetal weight less than 10%. Moderate fetal growth restriction is when a newborn is between 3 and 10%. And severe is when it's less than 3%. These kids have increased risk for perinatal morbidity and mortality. And you can have, and they usually are symmetric, as where all parameters are involved, and it usually tells you that it begins early in gestation. If it's symmetric fetal growth restriction. If it's asymmetric fetal growth restriction, is more related to something that happened at the second and third trimester, with decreased fetal nutrition resulting in a limited glycogen and fat storage. And I forgot the A between F and T, so that's fat storage. So characteristically, they have a head circumference that's preserved. Length sometimes is affected according to how long it has been going on for, and weight is significantly compromised in these children. So fetal growth restriction, you can have symmetric, where all parameters are less than 10%, not only weight, and you can have asymmetric. Symmetric happens from the beginning of early gestation. Asymmetric begins in the second and third trimesters. So that is different from small gestational age. So you can be fetal growth restricted, symmetric and small for gestational age. You can be fetal growth restricted, asymmetric and small for gestational age. So the definition for small gestational age is just having a birth weight less than 10%. That's it. So if you look at your neonatal charts in the nursery, you have between 10th and 90th percentile, you have appropriate gestational age. If it's above 90th percentile, you have large for gestational age. If you have less than 10th percentile, you're small for gestational age. And then constitutionally normal small gestational age versus being fetal growth restricted, right? So constitutional factors, maternal weight, height, ethnicity, and priority you take into account for just being small gestational age without being fetal growth restricted. If the kid is not fetal growth restricted and it's just small for gestational age because of these factors, then they're not at risk for perinatal morbidity or mortality, unlike the kids who are fetal growth restricted, who are at risk for perinatal morbidity and mortality. Okay, so growth pattern of postnatal events. So early growth parameters are normal. So if you have something that happens after birth, usually the early growth parameters are going to be normal, and then the parameters fall off the normal growth line, and all growth parameters are usually involved versus caloric insufficiency. So here it will be something like a kid with hypothyroidism that can have this happen versus B, not eating enough. First, it has significant weight loss or inability to gain weight. Then head circumference and height are initially spare. And in severe cases, all parameters eventually are affected. Now, in order to interpret growth patterns in older kids, older than just infants, we have to be familiar with a concept called bone age. So bone age correlates well with stage of pubertal development and can be helpful in predicting adult height in early or late maturing adolescence. In familiar short stature, so you have three different things, three different growth patterns. You can have a kid who's short because of familiar short stature or because of constitutional delay. In familiar short stature, the bone age is normal, comparable to chronological age. In constitutional delay, endocrine short stature, and on the nutrition, the bone age is slow and comparable to the height age. Skeletal maturation is linked more closely to sexual maturity rating than chronological ages, and skeletal maturation is more rapid and less variable in girls than in boys. So if you get a child who's short, first you have to determine is a disproportionate skeletal dysplasia or rickets, or is a normal variant. So if anything that is pathological, if it's proportionate, usually see if they had perinatal IUGR, placental disease, teratogens during pregnancy for the mother, if they have a dysmorphic syndrome like Down syndrome or chromosomal disease, right? If they are disproportionate and have skeletal dysplasia or rickets, this has to do with postnatal malnutrition, chronic disease, drugs, psychosocial dwarfism, and endocrine disorders. And the normal variants for short stature, once you determine it's a normal variant, are familiar short stature and constitutional delay. And you should be very familiar with these to be able to differentiate with something that's pathological. So in familiar short stature, you have normal growth velocity, and in constitutional delay, you also have normal growth velocity. In familiar short stature, you have normal bone age. In constitutional delay, you have delayed bone age, so your bones are younger than your age. In familiar short stature, you have normal timing of puberty. In constitutional delay, you have delayed time of puberty, because remember that sexual maturity is correlated with bone age. And adult height for familiar short stature, where you don't do anything, it's short. And usually for constitutional delay kids, they will acquire normal height. So be very familiar with this chart, because this is a fair question in any test you take, and also because you should know it. And when you look at a growth chart, you should be able to differentiate it. So again, constitutional delay is familial. They have normal birth weight and birth length. Then they have a downward shift between 6 and 9 months of age. It continues throughout 3 years of age. And children usually have a curve that parallels the lower third percentile. They have delayed bone age and delayed puberty, and they acquire normal height. So if we look at constitutional, the growth delay, which is this broken dotted blue line right here. So they are born, they hit 6 months, and then they start to go down. And if you follow, this is the second part of that chart, you see that they are on the lower, parallel to the third percentile, a little bit on top. And then when they hit puberty at 14 right here, he goes back up, or she goes back up and follows the normal curve, which is this 50 percentile in yellow. So that's constitutional delay. If you have a postnatal onset pathological short stature, let's say any endocrine abnormality, be it, hypothyroidism that is not well treated, adrenal insufficiency, whatever endocrine thing that can happen. Usually, they begin well, hold on a second. Let me track back. This is more, yeah, hold on. This is for height, yes, for height. So this, they start well, they're on the higher percentile, and then they start dropping off. And if you look at the weight, it might be higher than the height. For familiar short stature, they're always short. So they're born short, and they are short until they develop. And then for prenatal onset of pathological short stature, is this blue line. So, a kid who has, I don't know, Down syndrome or Turner syndrome, they're small, and they're always small, and they are far off from the curve. Okay, and actually this is not showing the y-axis, but this is age and this is height. Another thing that you should be familiar with is dental development. Okay, and I'm no dentist, so please bear with me. But these are the facts that you should be familiar with as a primary care physician, minimally, to be able to counsel your patients, okay? Because you get a bunch of people coming and saying, oh, my child is this age and he doesn't have a tooth yet. So the initial mineralization for teeth begins early in the second trimester. The mean age for central incisor is 14 weeks and continues through the third year of life for the primary teeth, and up to 25 years of age for the permanent teeth. So we start developing our teeth in the second trimester and finish by age 25. So some of you are still developing. Eruption begins with the central incisor and progresses laterally. Exfoliation, when the teeth, the primary teeth fall off, begins around 6 years of age and continues through 12 years of age. So that's the range. Eruption of the permanent teeth may follow exfoliation immediately or may lag for 4 to 5 months. Delay eruption is usually considered when there are no teeth by approximately 13 months of age, plus or minus 3 standard deviations. So it's mostly around 15 months of age. And causes can be hypothyroidism, hypoparathyroidism, familial, and the most common is idiopathic. Individual teeth may fail to erupt because of mechanical blockage like crowding, gum fibrosis. So if that has happened, you have to, by 15 months of age, if your child doesn't have teeth, you have to send them to the dentist. Early exfoliation, so having your teeth come out before the age of 6. The primary teeth includes entities such as histiocytosis X, cyclic neutropenia, leukemia, trauma, and idiopathic factors. Nutritional and metabolic disturbances, prolonged illness, and certain medications like tetracycline commonly result in discoloration or malformation of dental enamel. So a discrete line or pitting on the enamel suggests a time-limited insult that was systemic. And then when it comes to when do the teeth come out, the primary teeth. So lower anterior teeth or mandibular incisor emerge first, followed by opposing upper maxillary incisors. And the timing of primary teeth eruption is the rule of 7 + 4. At 7 months is usually when they get the first tooth. And then the next ones come at 11 months, so 7 + 4. And then you get 4 teeth, okay? At 15 months, which is 11 + 4, you get the next set. So by 15 months, you usually have 8 teeth. Then 15 + 4, 19 months, and 8 + 4, around 12 teeth. 19 + 4, 23 months, there's around 16 teeth. And that's at 23 months + 4, 27 months, and then 16, you usually get around 20 teeth, okay? So I put this here for you because I'm not a dentist, just to remind you of which one are the central lateral incisors, which are the maxillary and the mandibular ones, and kind of like see how they should come out laterally. And then here, there's a chart going over at what age they erupt and at what age they fall out. Okay, so just be somewhat familiar with this in case you get any teeth question, which you can see in any of your exams, and also so you can counsel your patients adequately. So dental care. If eruption of the first tooth has not happened by 18 months of age, refer to the dentist. The first dental visit is preferably by 1 year of age and not later than 30 months of age. It's very difficult to find pediatric dentists. And if you've worked in our clinic, you know that that's so true. So basically, we do the best we can because a lot of dentists won't take our patients' insurance. One of the biggest diseases in our clinic is cavities. And you know, we're still working very hard at addressing this. One of the things that I want to do is do the varnish, fluoride varnish, but I am not able to do it because we have to find a way of implementing and charging it. But that's one of our first goals because that's easier than finding dentists or pediatric dentists. So usually you have to tell your parents that as soon as they have any tooth out, they should brush from eruption twice a day, even if it's one tooth. Toothpaste with fluoride size of a grain of rice before the age of 3, and then pea size after the age of 3. And fluoride varnish recommended every 3 to 6 months after tooth eruption to prevent cavities. Hopefully someday we'll be able to do it in our clinic. And dental caries are you know, a combination of bacteria, usually S mutans, the most common one. So usually, you know, the risk factors to see a dentist at 6 months of age and no later than 6 months after the first tooth erupts, or 12 months of age, whichever comes first, should be done if you see that the child has the risk factors. And the risk factors are here: children with special healthcare needs, especially like cerebral palsy. Many times it's kind of hard for parents to have good dental hygiene with them because they have a clenched jaw. Kids who are premature birth, late order offsprings, children whose primary caregiver or sibling have caries, which is very common in our practice. Children with existing caries, plaque, the mineralization or staining, infants who sleep with a bottle or breastfed throughout the night. So we have to encourage parents not to do that when they have the teeth are erupted. Children who use bottle after 15 months of age, and children in families of low socioeconomic status, which is like 99% of our patients. Dental trauma. So all should be evaluated by a dentist. Avulsed primary teeth, do not reimplant them. So if it's a baby tooth or like a milk tooth, if it comes out, it came out. You don't have to do anything. But permanent teeth we have to try to reimplant. And how do you handle a primary tooth that has dislodged because of dental trauma? Do not scrub it. Just rinse it and to protect the root. They have this solution, Hank's solution or Save a Tooth solution to put them in. But if you don't have those, you use this is the algorithm. If you have cold milk. In kids who are older and old enough, you put it back in the socket and have the kid hold it, okay, in place until you get to the dentist. Physiologic saline solution or any isotonic solution, okay? Teeth that are left out after they come out for more than an hour have a very poor prognosis, but reimplantation should be attempted anyway. If you have and then on the other spectrum, nothing to do with trauma, if you have a kid who comes in with a dental infection, which we get all the time, the first line of treatment should be amoxiclavinate or augmentin or clindamycin. Most are due to aerobic bacteria, but dental abscesses are usually anaerobic bacteria are more common. And that's why we recommend these antibiotics. Sleep. So, SIDS is common in the 2nd and 3rd months of life and more prevalent in boys, premature birth, low birth weight, and twins. There's a Safe to Sleep campaign by the AAP for many years. And this is why we have to speak to parents about placing infants supine to sleep. since the implementation of the Safe to Sleep campaign, deaths have declined, although it has had the effect of having increased plagiocephaly or a flat back of the head, and slightly delayed motor milestones because it takes them longer to learn how to roll from front to back. But those are minimal things to do as long as we make parents aware of it, to avoid SIDS from happening. Breastfeeding and use of pacifier during sleep have an independent protective effect. And actually, the American Academy of Pediatrics approves using a pacifier during sleep as long as it doesn't interfere with breastfeeding. Colic. So colic and crying in children, because parents will come and ask you multiple questions about this. So a 2-week-old will cry normally for 2 hours. A 6 to 12-week-old can cry normally for 3 hours. A 3 to 4-month-old can spend 1 hour crying during the day. And the definition of colic is not a disease. It's a set of symptoms that we see in children who are less than 3 months of age. Usually colic, a child should be less than 3 months of age when it starts. It lasts 3 hours, 3 days a week for 3 weeks straight. As long as there's nothing else, you have to make sure there's nothing else wrong. Simethicone is safe but ineffective. I usually don't recommend it, but if a parent comes with it, I know that it's safe, so I will discuss with them how to use it. Do not change formula because kids have colic unless you have signs of lactase deficiency. In real life, the mothers bug you so much and it's become such a problem so many times, we will change it, but never on your test. Make sure that you have a crying infant, something else is not the cause, okay? They can have a corneal abrasion. I've seen hair tied around the digits or the penis, causing the pain, so you have to look everywhere. And don't forget that a coronary artery abnormality in a baby will present in the first few months of life with crying while they feed and sweating, like little baby exercise, and then chest pain. And if you have a baby like that, you may better send them to the cardiologist and make sure they don't have an abnormal coronary artery. Immigrants and internationally adopted children. We don't have a lot of international adopted children. We have a lot of immigrants every single month in our clinic. Okay. So recommended evaluation of children upon arrival to the U.S. includes the following: a detailed history and review system, including prenatal and genetic history, if available, measurement of length, height, weight, and head circumference in those who are less than 3, the head circumference, everything else and everybody else, routine screening for development, vision, hearing, and oral health, a comprehensive physical examination, particular attention to the skin, looking for rashes, bruising, scars, evidence of abuse, and neurologic exam, evidence of developmental delay, neurologic abnormalities. And laboratory tests include CBC to evaluate for anemia. You have to evaluate for infection, eosinophilia, and blood dyscrasias, okay? And serum lead level for children up to 6 years of age, and by a venipuncture, not finger stick, to avoid skin contamination. There are 22,000 international adopted children in the US. So this is something we should be familiar with. And when it says infection, usually we'll do a stool for ovarian parasites, and we can check that they haven't been exposed to hepatitis B, and if warranted HIV. Normal head shapes. So you should be familiar with the normal head of an infant. So you have your coronal suture, you have the anterior fontanelle, you have the sagittal suture, you have the lambdoid suture, and the posterior fontanelle. And these should not be when you feel the baby's head from birth to around 1 year of age. It's open here. This one closes earlier, and the sutures should not be overriding. If you have overriding sutures, then you have to look into it. So these are like all the things that can go wrong So, pliocephaly it's really in a normal head shape, but you can have just, pliocephaly that is uh, due to positioning, or you can have it due to craniosynostosis. So we'll go one by one, okay? So craniosynostosis is defined as a premature closure of the cranial sutures and is classified as primary or secondary. Primary craniosynostosis refers to closure of one or more sutures owing to abnormalities of skull development. Secondary craniosynostosis results from failure of brain growth and expansion. The incidence of primary craniosynostosis is approximately 1 in 2,000 live births, so it's pretty common. The cause of is unknown in the majority of children. However, genetic syndromes account for 20% of the cases of craniosynostosis. Cranial bones are well developed by 5 months of gestation. The brain grows well in the first year of life as long as the sutures grow at the same rate. The cause of craniosynostosis is unknown, but the prevailing hypothesis suggests that abnormal development of the base of the skull creates exaggerated forces on the dura that act to disrupt normal cranial suture development. And clinical manifestation and treatment. Most cases of craniosynostosis are evident at birth and are characterized by a skull deformity that is a direct result of premature fusion. And palpation of the suture reveals a prominent bony ridge, and fusion of the suture may be confirmed either by a plain skull X-ray or a CT scan or bone scan in ambiguous cases. So the most common craniosynostosis affecting a single suture is sagittal, the sagittal suture, and is 80% of the affected children are males. It's called scaphocephaly or boat shape. They have frontal bulging, prominent occiput, palpable keel ridge, and they have reduced biparietal diameter, and they really look like a boat here. Scasocephaly is a premature closure of the sagittal suture produce a long and narrow skull, or scasocephaly. It's the most common form of craniosynostosis. It's associated with a prominent occiput, a broad forehead, and small or absent anterior fontanelle. It's sporadic, it's more common in males, and it's often causes difficulties during labor because of cephalopelvic disruption. It does not produce increased intracranial pressure or hydrocephalus, and results of neurologic examination of affected patients is normal, okay? So if you do any surgical intervention, it's for mostly because of the way it looks. The coronal suture is 18% of all craniosynostosis and more common in girls, associated with Apert syndrome, which is, craniosynostosis with syndactyly, and also Crouzon's disease, which includes abnormal sphenoorbital and facial bones, and hypoplasia of the midface, which is this one. This is Apert, this is Crouzon's. So for the coronal suture, you can have unilateral pliocephaly. So unilateral is flattened forehead of the affected side, flat cheeks, nose deviation on normal side, higher suborbital margin leading to Harlequin sign or radiograph or on radiograph, and outward rotation of the orbit can result in amblyopia. I'm hearing somebody. I don't know who it is. Maybe you can mute yourself. You can have bilateral, which can give you brachycephaly or acrocephaly, and it's a broad flattened forehead in Apert syndrome accompanied by syndactyly, in Crouzon disease by hypoplasia of the midface and progressive proptosis. So frontal pliocephaly, and I have one patient with that, that never got, mother never got surgery, and it actually looks better now as she got older. It's the second most common form of craniosynostosis. It's characterized by unilateral flattening of the forehead, elevation of the ipsilateral orbit and eyebrow, and a prominent ear on the corresponding side. Are more common in females and is the result of premature fusion of coronal and sphenofrontal suture. Surgical intervention produces a cosmetically pleasing result, but it doesn't cause increased intracranial pressure. When imaging does not reveal a closed suture, positional factors are of primary importance to decrease it. Now, a lambdoid pliocephaly can be either as a result of how we position kids nowadays, or it can be a craniosynostosis. So you have to make the difference. So it's 20% of the craniosynostosis that we see It's lamboid, male to female ratio is 4:1. So it's if it's a lamboid occipital pliocephaly, right side affected in 70% of the cases. Unilateral flattening of the occipital indication along synostotic suture, bulging of ipsilateral forehead and leading to rhomboid skull. Ipsilateral ear is anterior and inferiorly displaced. If it's bilateral, you can have brachiocephaly with bilateral anteriorly and inferiorly displaced ears. So let me go over this chart here. So in this case here, this is craniosynostosis because you see that the lamboid suture kind of like closed. So what happens when it closes? It kind of like retracts the ear on the same side. As you can see here, like this ear is pushed back on the same side. And the other side keeps growing normally. That's if it's craniosynostosis. If it's pliocephaly, it's backwards. This is pliocephaly. This is from positioning. It's most often a result of positioning during infancy, more common in mobile child or child with a disability. Fusion of sclerosis of the lamboid suture can cause unilateral occipital flattening and bulging of the ipsilateral frontal bone. So here, this is not fused, right? So both sides are growing normally. So here, instead of retracting the ear, the ear is pushed forward. So this ear is more frontally on the side that you have the pliocephaly. The ear goes anterior and it looks like it's anterior to the other ear. And there's no fusion. While in pliocephaly, because it's retracting it back, because this is not growing, the opposite ear looks forward compared to this ear. You see that? So that's how you differentiate pliocephaly from positioning from lamboid suture craniosynostosis, okay? And then you have a bunch of other ones that I'm gonna go over quickly because it's almost time. So you have the metopic associated with chromosome 19p. It's a trigonocephaly, pointed forehead and midline ridge hypertelorism. You have trigonocephaly. It's a rare form. They shouldn't have keel-shaped forehead, like that cone head. You can have multiple ones. This is an actual picture from the 1900s. And you can have a cone-shaped head. You can have something called the kiboscatal deformity, which is called that resembles a clove lead. Affected children have very prominent temporal bones and the remainder of the cranium is constricted. They can have hydrocephalus as a common complication. Other facts, premature fusion of one suture rarely causes a neurological deficit. In this situation, the sole indication for surgery is to enhance the child's cosmetic appearance, and the prognosis depends on the suture involved and the degree of disfigurement. Neurologic complications, including hydrocephalus and increased intracranial pressure, are more likely to occur when there are two or more sutures involved or prematurely fused, in which case operative intervention is essential to avoid hydrocephalus. So syndromes, the most prevalent genetic disorder associated with craniosynostosis include Cruzon, Arpert, Carpenter, Croson, and Pfeiffer syndromes. Cruzon syndrome is characterized by premature craniosynostosis and is inherited in an autosomal dominant trait. The shape of the head depends on the timing and order of the suture fusion, but most often is compressed back to front diameter or brachiocephaly, resulting from bilateral closure of coronal sutures. The orbits are underdeveloped and ocular proptosis is prominent. Hypoplasia of the maxilla and overall hypertelorism are typical of facial features. And there you have one of Cruzon's. Again, craniofacial dystosis, shallow orbits, ocular proptosis, hypertelorism, frontal bossing, exposure of the conjunctivitis and keratitis, premature craniosynostosis, especially of coronal, lamboid, sagittal sutures with palpable ridging. They have hypoplasia of the maxillary with or without curved parrot-like nose, inverted V-shaped to palate. They have conductive hearing loss. Is an autosomal dominant with variable expression. 1/4 are fresh mutations in the fibroblast growth factor receptor 2 gene. And Cruzon syndrome, they can have with acanthosis nigrans is an entity called CAN. It's associated with craniosynostosis, ocular proptosis, mixed phase hypoplasia, choanal atresia, hydrocephalus, acanthosis nigrans, and it's in the FGR3 gene. Apert has many features in common with Crouzon syndrome. Apert syndrome is usually a sporadic condition, although autosomal dominant inheritance can occur. It is associated with premature fusion of multiple sutures, including the coronal, sagittal, squamosal, and lamboid sutures. The faces tend to be asymmetric, and the eyes are less proptic than in Crouzon syndrome. Apert syndrome is characterized by syndactyly of the second, third, and fourth fingers, which may be joined in the thumb and the fifth finger. Similar abnormalities often occur in the feet. All patients have progressive calcification and fusion of the bones of the hands, feet, and cervical spine. And this is Carpenter syndrome. It's an inherited autosomal recessive condition and can and the many fusions of sutures tend to produce a cuboidal skull deformity. Soft tissue syndactyly of the hands and feet is always present, and intellectual disability is common. Additional but less common abnormalities include congenital heart disease, corneal abnormalities, and genius valgum. This is Clausen syndrome. Is characterized by asymmetric craniosynostosis and plagiocephaly. The condition is the most prevalent of the genetic syndromes and inherited autosomal dominant trait. It's associated with facial symmetry, proptosis of the eyes, shortened fingers, and soft tissue syndactyly of the second and third finger. Pfeiffer syndrome and is most often associated with terucephaly. The eyes are prominent and widely spaced, and the thumbs and great toes are short and broad. Partial soft tissue syndactyly may be evident. Most cases appear to be sporadic, but autosomal dominant inheritance can be reported. And the genetics, finally, is mutations of the fibroblast growth factor receptor gene family have been shown to be associated with phenotypically specific types of craniosynostosis. Mutations of the FGFR1 gene located on chromosome 8 results in Pfeiffer syndrome. A similar mutation of the FGFR2 gene causes Apert syndrome. An identical mutation of the FGFR2 gene can result in both Pfeiffer and Crouzon phenotypes. Each of the genetic syndrome poses risk additional abnormalities, including hydrocephalus, increasing intracranial pressure, papilledema, optic atrophy resulting from abnormalities of the active foramina, respiratory problems secondary to deviated nasal septum or corneal atresia, and disorder of speech and deafness. Craniectomy is mandatory for management of craniofacial team. It's essential for the long-term follow-up of these children. And craniosynostosis may be surgically corrected with good outcomes and relatively low morbidity and mortality, especially for non-syndromic infants. And that's the end. Thank you.
Perfect. Thank you, Dr. Mendez.
Thank you, Dr. Mendez.
Thank you, Dr. Mendez.
Have a good day.